Beta blockers are the drugs that block beta-adrenergic receptors. Most of them block beta-1 receptor, some of them block beta-2 receptor, and only few of them can block beta-3 receptor. These drugs can be divided on two classes. We have selective and non-selective beta blockers. Non-selective beta blockers block both beta-1 and beta-2 receptors. Non-selective beta blockers can be divided on two generations. To the first generation, we include nadolol, propranolol, and sotalol. These drugs are the classic beta blockers. But also, we have the third generation of non-selective beta blockers, and these drugs have the additional effects. For example, carvedilol also block alpha-1 receptors. So to explain the effect of beta blockers, we have to know the location of beta receptors in our body. First of all, we have beta-1 receptors in the heart. The activation of beta-1 receptor causes increase in heart contractility and heart rate, which is important for regulation of the blood pressure. Recall that blood pressure is equal to cardiac output on systemic vascular resistance, and cardiac output is equal to heart rate on stroke volume. Increase in heart contractility causes increase in stroke volume, and together with increase in heart rate, this causes increase in the blood pressure. So beta-1 receptors participate in regulation of the heart rate and blood pressure. Also, we have beta-1 receptors in the kidneys, where beta-1 receptors stimulate the production of renin. Increase in renin production activates renin-angiotensin-aldosterone system, which plays a crucial role in the regulation of the blood pressure. Recall that blood pressure is equal to cardiac output on systemic vascular resistance. Activation of renin-angiotensin-aldosterone system causes increase in systemic vascular resistance, and by this blood pressure increase. So beta-1 receptors in the kidney tissue also participate in regulation of the blood pressure. In the vasculature, we have beta-2 receptors. Beta-2 receptors provide vasodilation. Recall that blood flow is equal to pressure difference divided on resistance, and resistance is inversely proportional to the force power of radius. So activation of beta-2 receptors causes dilation of the blood vessels. Radius increase, resistance decrease, and thereby blood flow increase. So beta-2 receptors are involved in regulation of the blood pressure. So beta-2 receptors are involved in regulation of the blood flow. Also, we have beta-2 receptors in the airways, where activation of beta-2 receptors provides bronchodilation. Recall that airflow is equal to pressure difference divided on resistance, and resistance is inversely proportional to the force power of radius. The activation of beta-2 receptors in the airways causes bronchodilation. With bronchodilation, radius increase, resistance decrease, and with decrease in resistance, airflow increase. So beta-2 receptors are involved in airflow regulation. And also, we can find beta-2 receptors in the liver tissue, where activation of beta-2 receptors stimulate glycogenolysis, and activation of glycogenolysis causes increase in blood glucose level. So beta-2 receptors are involved in regulation of the blood glucose level. The first class of beta blockers are non-selective beta blockers, as nadolol, propranolol, and carvedilol. They all block beta-1 receptor in the heart. By this, contractility decrease and heart rate decrease. With decrease in contractility and heart rate, the cardiac output decrease and thereby blood pressure decrease. Also, beta blockers block beta-1 receptor in the kidneys. With blockage of beta-1 receptor, the production of renin decrease. Thereby, the activation of renin-angiotensin-aldosterone system decrease, so systemic vascular resistance will decrease, and thereby blood pressure decrease. So beta blockers can regulate blood pressure. In addition to this, non-selective beta blockers block beta-2 receptor in the vasculature. With blockage of beta-2 receptor, vasodilation decrease and thereby blood flow will decrease. So, in which conditions we can use beta blockers? First of all, we can use beta blockers for hypertension because they decrease blood pressure. Also, we can use beta blockers in case of angina because they decrease cardiac output and thereby they decrease workload on myocardium, which can decrease the severity of ischemia. Also, we can use them in case of supraventricular arrhythmias because they decrease heart rate. Because beta blockers decrease the activity of renin-angiotensin-aldosterone system, they decrease blood pressure, so it's another reason to use them in case of hypertension. And also, because non-selective beta blockers block beta-2 receptor, they decrease blood flow, and important that they decrease blood flow in splanchnic circulation. And it's the reason why non-selective beta blockers are the most commonly prescribed drugs for prophylaxis of esophageal variceal bleeding in patients with portal hypertension. But non-selective beta blockers have also significant side effects. First of all, they block beta-2 receptors in the airways. They decrease bronchodilation and thereby they decrease airflow, which can be dangerous in patients with asthma or COPD, which is why we try not to use them, especially in case of asthma. Also, beta blockers block beta-2 receptor in the liver. They inhibit glycogenolysis, which can cause substantial decrease in blood glucose level, so they can cause hypoglycemia. And it's the reason why we try to avoid them in case of diabetes. Among non-selective beta blockers, carvedilol is quite a unique drug, because it also blocks alpha-1 receptors, and because of this, carvedilol is more potent antihypertensive drug. Selective beta blockers block primarily beta-1 receptor, and they have minimal effect on beta-2 receptors. We have two generations of selective beta-1 blockers. The second generation include atenolol, bisoprolol, and metoprolol. The third generation include nebivolol and betaxolol. So, what is the difference between non-selective and selective beta blockers? If we prescribe beta-1 selective blockers as bisoprolol, metoprolol, atenolol, and nebivolol, they block beta-1 receptor in heart tissue, so they will also cause decrease in heart contractility, decrease in heart rate, and thereby decrease in blood pressure. So we can use them for hypertension, angina, and arrhythmias. They will also block beta-1 receptor in the kidneys, so they will cause a decrease in renin production, which will cause decrease in blood pressure. But the difference is that beta-1 selective blockers do not block beta-2 receptors, which is why they do not block vasodilation. So unfortunately, they are useless for prophylaxis of esophageal varices in case of portal hypertension. But what is great about them is that they do not block beta-2 receptors in the airways, which is why they do not block bronchodilation, and thereby they do not decrease airflow. So we can use them in asthma patient or in patient with COPD. Beta-1 selective beta blockers do not block beta-2 receptor in the liver tissue. Because of this, they do not inhibit glycogenolysis, and thereby they do not cause decrease in blood glucose level, which is why we can use them in patients with diabetes. There are also some specific features about beta blockers that we have to know. Timolol, which is non-selective beta blocker, decreases the production of aqueous humor in the eye, which is why we can use timolol in patients with glaucoma. Propranolol, which is also non-selective beta blocker, inhibits the conversion of T4, which is less potent thyroid hormone, to T3, which is more potent thyroid hormone. And because of this, we can use propranolol in patients with hyperthyroidism, especially in case of thyroid storm. For variceal bleeding, we can use only non-selective beta blockers, because we need to block beta-2 receptor. Unfortunately, sometimes beta blockers can provoke erectile dysfunction. It's not very common side effect, but certainly very serious one. Among selective beta-1 blockers, there is one drug that stands out. It's nebivolol. Nebivolol is quite a unique drug because it blocks beta-1 receptor, it blocks beta-3 receptor, and also it stimulates NO synthase, which produce nitric oxide. And nitric oxide causes vasodilation, which causes decrease in systemic vascular resistance. So nebivolol is one of the most potent beta-1 selective blockers in case of hypertension. So if we have to summarize, adrenergic blockers can be divided on alpha blockers and beta blockers. In turn, beta blockers are divided on non-selective and selective beta blockers. Non-selective beta blockers can be divided on first and third generations, among which we have to know that carvedilol also blocks alpha-1 receptor. And selective beta blockers can be divided on second generation and third generations.